and welcome to Psyched for Sanity. I am one of your hosts, Dr. Brindle Doss. I'm a licensed clinical psychologist specializing in assessment, forensic psychology, geriatric psychology, and the treatment of trauma.
And I am Dr. Tara McKelvey Parker. I'm also a licensed clinical psychologist. I specialize in assessing and treating complex trauma and attachment wounds from childhood. And my little tidbit of information for today is that I have a lot of issues with food.
I've noticed that over the years.
A lot of people tell me that I eat like a 5-year-old child. There are a lot of foods that I do not want to eat, and I don't know. There's like a combination of factors I think that go into this. One is like sensory related, like mushy stuff.
Yes.
You know, like really bothers me.
Gotcha.
I can't eat it.
Okay.
But also I have a lot of like phobic tendencies around food, like fear.
Phobias.
Exactly. To eat like new foods that I've never eaten before, or like there's something about creamy, like milky based things that I have issues with. Like I won't eat ranch. I won't have like sour cream. I don't do like, what are some other like creamy, like kind of
Cottage cheese?
Cottage cheese. Ugh, won't do cottage cheese. Yeah, stuff like that. And so the only thing I have come up with that potentially bears weight here is that I have a few instances of accidentally eating really rotten or like nasty cream-based things that potentially have contributed to some like avoidance, like, you know, like fear and avoidance of this food. One that I remember specifically, I was probably like 10 and I was with one of my like dearest friends at the time. And, you know, like 10, we were like probably like 10, 11. And, you know, we were like doing our sleepover thing where we were like choreographing Spice Girls.
As you do.
Songs. Yes. And like.
They always made me be Sporty Spice.
I always
I don't know
wanted to
why.
be Baby Spice.
I mean, I'm kidding. I do know why. Go ahead. Continue.
Because you're sporty?
Yeah. Yeah.
Well, yeah. Anyway. So, you know, like when you're doing a sleepover.
Yes.
You stay up really late and you go raid the pantry.
Yes.
Yes. So we went and we like raided the pantry, and one of the things in the pantry were Twinkies. Oh. And that's wonderful. Twinkies are...
They're supposed to have the shelf life of like a massive shelf life.
Yeah, well, those Twinkies must have been in there for a really long time.
Oh my gosh.
Because I opened it and took a huge bite and was immediately like, what is happening? It was dry. It wasn't moist. There was no cream. I looked down and there was mold. It was just like all molded, this Twinkie.
Ow.
I have not had a Twinkie since then.
Well, how could you?
It was disgusting and very disappointing. We had no sustenance for our Spice Girls dance choreography.
Right.
So.
Yeah. I hate bananas and avocados.
Okay.
Hate them.
Okay.
I don't know why.
A strong word.
Yes, no, but
don't tell the bananas and avocados.
I mean, they know. Oh. They know. No, I have not. So when I was young, I think it was a Saturday morning, and I was given bananas for breakfast. And I ate bananas as a kid, but this morning I was refusing to eat my bananas.
Okay.
And my parents decided that if I was not going to eat my banana for breakfast, I would have it for lunch. And I had to eat a really mushy, in my word, just my opinion, nasty banana.
Okay.
And I've never eaten them since.
Oh,
Ever.
my.
Ever.
So you must have some real, like that mushy texture.
Oh, yeah. I also have sensory food issues like you, I think.
Yeah.
But I do eat cottage cheese. I'm fine with other things with cream. I do ranch, sour cream. I'm fine with all that. But bananas and for some reason avocados. It's it's the foods that start off vaguely solid and get mushy as they go.
Deteriorate over time.
Yes, as you consume them, they get softer.
Well, that's true because I'll do a banana when it's like it's newer.
Firm.
Yes. And then it gets mushier, and I can't either. Yeah, okay. Well,
but I don't know why avocados, but never bananas again. I know why I do not eat bananas.
But you don't know why you don't eat avocados.
No, yeah, no.
But they can be kind of mushy, and they also
they start off
mushy.
solidish, and then they get really soft.
Will you eat an avocado? You don't do bananas at all, but will you eat an avocado when it's like more ripe?
No.
No. Okay, so
you
have no rhyme or reason
if
to.
there's any like avocado in my sushi, I will literally pick it out.
Okay, I do that too, though, with like other things. I don't eat avocado either, and I'm not a super fan of bananas, even though all this stuff is like so great for you.
It's very healthy for us. And the other thing now, like we have kids, and the kids like love bananas, and I'm like,
Unfortunately, I'm probably passing along some of my food aversion to my own child
because I'm not allowed to do that.
Well, I'm real picky. I'm real picky. So like I'm picky. My kid is picky. I wonder where that.
No.
Maybe we should get some
therapy.
Some therapy.
Yes.
Yes. To like help.
There are therapies that address food phobias or food avoidance. Yeah. There's lots of therapies for lots of things. And you know what I realized?
What?
You know how we talked about how to find a therapist?
Oh, like on one of our one of our podcast episodes in the past.
Right. Mm-hmm. We finished that episode. Yeah. We're all like happy about it. We're excited. We're like, oh, that was great. And then one of our amazing engineers and producers, Rudy, was like, this is embarrassing. And we're totally genuinely, for our listeners and our viewers, fully acknowledging our privilege here and our complete and utter lack of insight. We completely
awareness.
Yeah, in the moment.
Yeah.
We did not talk about the underinsured or uninsured in terms of finding a therapist, because those people also are a large majority of the population. Mm-hmm. And even if you have health insurance, sometimes you have a large deductible, which means you pay full fee, your therapist's full rate.
The full,
before your deductible kicks in.
Yep.
And so that is...
It's very, very expensive and not doable
cost
for a lot of people.
Absolutely. So we are acknowledging for our listeners and viewers, we apologize. Yeah. And we want to thank Rudy for his awareness and kindness in mentioning that. Because it's a huge topic when it comes to finding a therapist. It's not just about fit. Mm-hmm. It's not just about schedules matching, things like that.
Yeah.
There's so much more that we really didn't talk about in that first episode.
Yeah. So I think we've got several additional details we'd like to share with you guys about how to find a therapist. Part 2.
And the process that goes into that, like what it looks like in the moment.
Yeah. So maybe we should start with the, not insured,
underinsured or uninsured for sure.
Mm-hmm. Yeah.
So where can people that don't have any insurance, where can they find a reasonable, and reasonable is a loaded word, fully acknowledge that what might be reasonable for one person is not reasonable for the other. Mm-hmm. But where can people find no cost or low cost therapy or counseling?
Well, I think one of the first places to start is by, going through some of the steps we outlined in the first episode about finding a therapist,
sure,
in private practice or whatnot. And I would inquire about sliding scale.
Explain what sliding scale is for folks.
Sliding scale. So probably, I know myself and who I work with, and I know you do, yes. We offer a certain amount of sliding scale spots
on our caseload.
On our caseload.
So let's say I might carry a caseload of 15 different patients or clients. Mm-hmm. Of that caseload, maybe I allot 2 to 3, maybe more.
2 to 3, yeah.
That are going to have lower cost sessions based off their income or based off other factors.
Based on, and some providers will have a flat fee sliding scale cost, okay. So it won't necessarily depend on what the patient is able to do necessarily. This is what they're comfortable sliding down to,
right?
But for others, like myself, I usually take into account these factors.
Me too.
So. Yeah. I will often ask, people what they can afford to pay, and usually we'll go with that. I don't have this is the minimum I'm willing to take. I usually do 3 on my caseload, and I would say historically I don't have one right now, but for the most, because she just terminated, but for the most part, I have one pro bono case.
What's pro bono mean?
Pro bono means free, because, mm-hmm. I want to help someone who just really can't do it, or,
right.
Can maybe only pay $5 or $10.
Right.
So that sliding scale, I would start there, because many professionals, many psychologists, therapists, they will offer sliding scale, maybe right. even pro bono.
They don't often advertise that, but a lot of them do. So even though it might feel uncomfortable to call and make those inquiries, which we totally acknowledge and understand, mm-hmm. I definitely think if you find someone that you really would like to try to work with, I don't think it ever harms anyone to ask. Yeah, I'm never offended by anyone asking.
No, and I've actually had quite a bit of people. I've even had people ask for sliding scale testing, and I've done it before.
Right.
So just like a reduced rate for testing, because it's also massively. A lot of people cannot afford expensive. Testing.
Right.
So, I also think about reaching out to any kind of like college or college campus or training center for psychologists to see if they have a clinic, like a low cost or free clinic.
Probably not just psychologists, probably master's programs for LPCs,
therapy,
counseling,
exactly.
or psychology programs. So they often have community clinics.
Yeah, like a clinic attached to it. So I went to UNT.
Okay. University of North Texas.
Yep, for my PhD. And we had a college counseling center that was just for students.
Okay.
But then we also had like a community clinic.
Right.
That was a training clinic.
Yeah.
So I would take on cases at each site.
Right.
And so the community clinic would offer therapy for a significantly sliding scale. I mean, I think people were paying like $5, $10, $15, even reduced fee testing at the UNT clinic.
Yeah.
I know it still exists and it's still a training clinic. So if you're anywhere up or around Denton, that
or
would be
in the Dallas-Fort Worth area.
Yeah, of course, if you're willing to drive.
Yeah.
And it could totally be worth it if you get something, you're able to. It's usually, master's level or PhD level trainees. We're getting hours, we're learning, and we're supervised by PhD psychologists.
Who are licensed.
Or
licensed professionals, yeah.
So you kind of get the benefit of someone who's in training and also someone who has their degree and who's had experience.
Right.
UT Southwestern also has a clinic like that.
Right. Well, Texas Christian University, one of my alma maters, they're starting a master's program and counselor. I believe it's a counselor ed program in the psychology department. I think I might be inaccurate in some of the details of that, but that's another opportunity if they have any of those clinics to do that. But another big area of places people can go is what called community mental health centers. And a community
not attached to college counseling, because it's all kind of community mental health,
right?
Yeah.
And these places are usually funded from the county or maybe even the state level at different points.
Probably.
And they also offer low or no cost sessions to people in the community that are under or uninsured. And there can be longer wait times for certain elements of their service, for sure.
I would say,
but
there probably are,
right?
Yeah, like wait lists for these services because they are sought after.
But this is just occurring to me, like even just the timeline to get in to see a therapist, even if you have
that's true.
Whatever good insurance is for you, like can be.
Sometimes it can be a long time. Yeah,
it can be a long time.
I would just encourage folks, if they hear this and they're thinking about therapy and they do need sliding scale or community mental health, just get on top of it now, because you may be waiting a few months to be able to see a therapist, and maybe a little longer for testing. But especially for testing, I think it's worth it because it can be pricey,
beneficial. Yeah.
So, yes, community mental health. So like MHMR.
Yes.
Is the one here
in Fort Worth,
Tarrant County. Metro Care is Dallas
County.
In
City
terms
of Dallas.
Community mental health.
Yeah. And actually that's where for my internship I worked. One of my major sites for my internship was in Wichita, Kansas at a community mental health. It was my primary.
Yeah.
It was a community mental health center. And so I was a doctor in but my final hours. And so I'd already been through for 3 or 4 years of training and doing therapy. And I went up there and I was still supervised by a licensed professional and provided therapy and assessment to folks in the community. And anyone could come.
Reduced cost.
Yeah. Yes. Reduced or no cost for sure. So now that we've kind of talked about some options for folks kind of broadening that umbrella, again, thank you to Rudy. What else, when they think about going into therapy?
Yeah, what should we kind of expect?
Yeah, what else is involved? Because it's like if you've never done it before, it can feel weird and uncomfortable. And we definitely want to demystify that process.
Yeah, I mean, so what can people expect? Paperwork.
What's the first step? Right, paperwork.
Yeah, usually once you reach out to someone and you've, confirmed that you have like mutual availability and they're taking new patients and it feels like, a good first step, usually you schedule an initial meeting, like a clinical intake, and then you fill out paperwork.
Yeah.
So the paperwork is just like consent for treatment, demographic information, Usually there's their notice about privacy policies and what they, can HIPAA and cannot disclose. Mm-hmm. Yeah, all of that you sign. And then maybe like some clinicians have brief questionnaires about like, why are you coming? What are your symptoms?
Mine's not brief.
It's longer.
Oh yeah.
Mine's pretty brief.
Really?
Yeah. I do glance at the paperwork to see what I'm getting into, but I really like wait for the clinical interview usually to get like my.
So I'm the opposite. I have them fill out a really full history form.
Okay.
It's not full where they're like completing like, tell me about your relationship with your second grade teacher. But because that's a bit too much even for me. But who do you live with? Mm-hmm. Who are where do you live? How long have you lived there? Have you had any recent jobs, like any symptoms you're having? Mm-hmm. How's your sleep?
Yeah, yours is
How's
long.
yours? Are you consuming any illicit substances, which might be negatively impacting your physical and mental health? Have you had any thoughts of hurting yourself? Like kind of a full, vocational history.
Okay.
Like, and people, I don't expect people to write like long paragraphs or sentences in this, but it gives me enough during the clinical interview to hit the points where I'm like, I need to get more data on this. Or
so you kind of use your intake paperwork as like a guide,
as a rubric, absolutely,
for like where to go.
100% as a roadmap.
Okay,
especially if people. It's always fascinating to me as a clinician when people leave things blank. Yeah, like everything else is filled out, and this one question.
Don't scare people into thinking.
No, it's not scary, but it must have been. You know what it tells me as a psychologist and a clinician? There must either it was an honest mistake, which happens. They forgot.
Yeah, or it's something that's tough,
or it's private and sensitive, and that helps me.
Challenge. Yeah, exactly.
Be delicate with it. Yeah, so I was saying like, I noticed you didn't mark this. Was that like just an oversight, or is there something around this that you need me to know? That you'd rather say in person.
Okay, so you like use your paperwork as a tool.
100%.
Okay, I'm not like that. It's more brief, and then I want to like just get a feel from the get-go in the room with the patient, and I just sort of usually have like a few questions that I'll ask, and then I go where my patient wants to, and that's data, I suppose. So
absolutely.
I think I wait to collect.
Interesting.
In the moment. So you see, we all
have
different styles of but you will get some form of paperwork.
Yes.
And you could potentially evaluate what you like and don't like about their paperwork style, right?
Absolutely.
Because when you were talking, I was thinking about the paperwork thing. And I think I might be one of those people who would like to fill out more data beforehand because I want like my therapist to see me, right? Like I think it would be cool to like put all of that information in paperwork and like
most people, not everyone. Everyone has. Some people fill out minimally, and that's fine too. Like I'm not upset with anyone if they don't put a lot of data on there. Mm-hmm. But I just do kind of what you do organically, so there's less data. Mm-hmm. I'm like, well, yeah, and like if most of the document is relatively blank or minimal, I'm like, okay, then I kind of just go over the document with them and almost fill it out with them.
Well, but so I have you really like adjust depending on.
Course,
I mean, you use it as a tool.
But I have like asked people to reschedule if they come without that document.
Oh yeah, because then maybe it signals they're not quite.
It can. Maybe not quite ready. Or I've asked them to sit in the waiting room and fill it out if they forgot. Mm-hmm, mm-hmm. And that's like, again, no judgment with that. It's really a big part of my process. And each therapist, clinician, psychologist, what have you, social worker has their specific process. And I know I work best this way. And so I try to have patients.
And will, your patients will vibe with you because of your style.
Right.
And my patients will vibe with me because of mine. So no right or wrong, different personalities.
We're going to get to that in a minute.
Styles. Yeah.
Yeah.
In terms of fit. But, there will be some form of paperwork, some form of initial clinical interview and whatever style that looks like.
Yeah.
And then, I think one thing maybe people don't always know if they're using insurance.
Yes, tell them.
Is that insurance requires a diagnosis for treatment.
Most insurances, we just put a caveat, most. I've never come across one that doesn't.
Which ones don't, but.
Right, I just want to put that caveat.
But you do know some do not?
I've heard in the past, I think less so today. I think you're correct that the majority of ones that I've come across do require you to enter something.
Something. That has been my experience in taking insurance, but I don't, So, you have a right to know your diagnosis.
Yes, you do.
You have a right to ask about it. You have a right to discuss before anything is decided.
Sure.
I think just most patients don't know that's part of the process. They don't even know to ask or to discuss.
Yeah.
I probably didn't know I don't know that I knew or had discussed or knew my diagnoses in therapy probably until like my 5th therapist.
Interesting.
Patients do have a right to discuss before anything is sent to insurance,
Sure.
their diagnosis. And
I kind of try to towards the end of that first clinical interview or intake. If you, I try to talk about what symptoms I'm seeing and how this would fit. And I do try to talk about, and a lot of times it's a really great place to start in terms of the clinical work, because sometimes people know diagnosis and labels out in like pop culture and society. They've heard of these terms. But when they're hearing their experiences as I'm telling them back to them, or their symptoms back to them, and I'm saying this means this means this means that, and I've had a lot of people like, oh, I never thought of that. Or, oh, I didn't realize. I didn't realize. And so it can be a really helpful place to start off that work and kind of keep us really focused in session. So it's not like they're chit-chatting with a friend. You know what I mean?
Sure. Yeah.
Sometimes there's a tendency to start that way because it's uncomfortable and new. You know what I mean?
Like first session or whatever.
First or second session can be like, okay, but I think that helps me. I always like the second session. I always like to say, well, what have you thought about since our last session? And I also add, it's okay if you haven't thought about it at all. Because a lot of people, once they leave, they're done, which is fine. But a lot of people are like, well, no, I thought about this after you said that, or da-da-da-da, and that kind of gets us into the work, if you will.
Yeah.
So yeah, definitely you have the right to know what the terms of the diagnosis and understand that. What else should they know about the room and the experience in therapy?
One other thing I thought about that we didn't necessarily talk about that could be important is that you can't have 2 therapists.
Right.
Unless they serve different roles. Because it could be, if you were seeing, someone like me and Dr. Doss at the same time, who are, we've got our specialties, but we're pretty general. We can treat a lot of different things. We'd probably be doing talk therapy.
Most likely.
That would not be good because it would be a conflict of interest. We have, as you can tell, we have different styles, right, of treating and different specialties. We're doing our intake paperwork wildly differently, right? So we would probably be tackling a similar issue in like a potentially different way, and so then you're going to get differing potential feedback, not because either one is right or wrong, but because it's just different and it might not necessarily mesh well together. And there's also lots of relational.
Also could be like repetitive and redundant.
There's also like, again, relational themes that can show up when you have 2 therapists, depending on your psychology, right? Your history, like that might how you create some kind of conflict or anxiety or, whatever. I think that would be really challenging. So, but,
So when can they have more than one?
Yeah.
Like in what roles?
It would different roles. So like you could see Dr. Doss or me for individual therapy. And then if you were wanting to do couples therapy, for instance, that would be totally fine. Different mode of therapy.
Absolutely.
And oftentimes very helpful, I think, to do couple, if you're having couple issues, to do couples therapy with individual.
Yes.
And then, at least in my practice, we consult together.
Yeah.
Right. With your consent, of course.
Well, you have signed releases for that, of course.
Yeah. But that can be really, really helpful. Myself, like I have a home base, like talk therapist that I've been seeing for years. But on the side, I have done internal family systems intensives.
A very specific type of
trauma treatment that really doesn't conflict at all with my individual therapy. Right. And there's enough of a difference in roles that I don't feel a conflict, about loyalty or whatever.
Right.
To, so it's like that. If you were going to have a talk therapist where you were working on trauma-related things, but you wanted to get some cognitive behavioral therapy on the side, it's a very specific manualized treatment that can be very helpful in conjunction, I think, when you have a home base sort of generalist, maybe working on like underlying issues.
I think the main thing, if you're talking about anytime you're looking at more than one therapist in the dynamic, always disclose to all the therapists, this is what I'm seeking treatment from Dr. Parker for. Can I come to you for this?
Yeah, that would be a great way to just bypass issues.
If you're concerned, like, well, I'm not really sure. I'm seeing Dr. Parker for my depression and my trauma. Can I go to Dr. Doss for EMDR? And I'm like, well, you know what I mean? And so that's very specific intervention, and it's time limited.
And that would probably be totally appropriate if you had like a talk therapist and then you just wanted to go do EMDR. Again, like a manualized treatment that's very specific.
And time limited.
And time limited. And it's, you know, it's not really going to conflict with the overall work you're doing in your...
And EMDR stands for eye movement desensitization reprocessing therapy.
I'm very impressed that you remembered that. Oh, yeah. I literally am always like,
absolutely.
EMDR, eye movement.
I got all the letters.
You are really good at letters.
Yeah, no, and so that's sort of how to handle like multiple therapies or multiple interventions. How would they know? How would a person listening or watching know if their therapist is a good fit?
See, I had to think about this one because I knew we were talking about it. I was like, how do I know my therapist is a good fit? Like, this is one of those questions. It's one of these questions.
Yeah.
I think hard. For me, because I'm pretty intuitive, emotional, like, you know, it's just like a vibe.
It's a vibe.
It's just like a vibe.
Wow, how very Gen Z of you.
I feel. I was told last night I look younger than I am.
Congratulations.
So thank you. So it's kind of like a vibe for me. It's a feeling. So this morning I was like, okay, like what makes the vibe good? Like what exactly is it for me? And I think for me, you know, my therapist, I pick out older women that are maternal.
Okay.
This is something I always do.
Interesting.
That are warm, non-judgmental.
Right.
Like relatively relational. So there's not like just another person sitting over there that I'm talking at. Like some people prefer that, right?
Sure.
But I do not. That freaks me out. So she's like a real person.
Yeah.
She's a human. Like we have a relationship. Sometimes she shares little tidbits about her life, but it never feels inappropriate or not boundaried.
And it never takes up the space and time of your session.
Right. So I love all of those things about my current therapist, and I just feel safe and comfortable being there.
Right. I think the same. So when I look for a therapist or a clinician to see for myself, I need to be able to feel after 1 to 2, maybe 3 sessions that I can be vulnerable. And authentically myself, and that I don't have to censor myself or limit myself in session. And I have to feel like, even if I'm not feeling 100% better, which that's an unrealistic goal, I feel like I need to get the sense that we're on the path to helping me have a different view of myself or a different experience. And that, in my opinion, just professionally, that's the ultimate goal for anyone. Therapy.
Yeah. And I would add just a little caveat,
Please.
You know, because I'm still working on being vulnerable with my therapist, and I've been seeing her for like 8 years. So it may take you longer than a few sessions to feel safe, or to feel like you can be vulnerable. But I think I just want to like definitely safety. Like this is a person that you could sense would be okay with you being vulnerable. Over time. And that is sometimes a felt sense, and why it's kind of feels woo-woo. It's a little hard to... but
sometimes, but we're in mental health. We're going to get woo-woo at times.
I get woo-woo at more times.
What about, when should a person, like what are some signs that a person should discontinue their treatment with a certain therapist and find a different one?
Yeah, this is also like, it could be a little vibey, right? But there are like some... I'm impressed, A. B, I'm shocked. And I'm like happy that you're like so on the money with these. Like this, it's just very much not you to be like so up with the lingo. Oh, well, I just don't know how cool I really am.
I've always said you're cool. I just didn't know you were this cool.
I'm feeling myself today, guys. Lots of comments.
All right, focus. Sorry, I derailed us.
You are. Okay.
I did.
Okay, to know it's not a good fit.
Maybe it's just not working. It's not helpful.
Working. Yeah.
Right.
Well, you know, I think I don't know, you mentioned goals earlier, that you want to know that you and your therapist are working towards some kind of shared goal, or like
that I'm usually driving,
that you're usually driving,
as the patient.
Yeah, I think that is an important thing to consider. Like if you're if you're with a therapist and you have a goal, you know, and if you're feeling like over time you're not meeting the goal,
sure,
like it could be a good time to consider maybe switching.
After a number of sessions, if you still like your symptoms are like not getting any reduction in your symptoms or any new insight whatsoever, for sure.
Yeah, if you're not feeling some sense of relief or, enjoyment about going, I think it could look different. Everyone has different goals, but so I think that would be a good one.
Okay.
What do you think?
I think that if you feel, so this is also like, especially if you're starting off, if the therapist does something that makes you feel drastically uncomfortable or unsafe in the room, and then I think you and I might have different opinion on this.
We might, yeah.
I am actually okay as a clinician being ghosted.
Oh yeah. I mean, I'm not okay with it, but I'm.
But listen, because it's so hard, and there's even if I try to minimize the power differential between me and my clients, it's so hard if there's just not the right vibe. And I can't be the right human person, clinician for my patient or my client. I'm okay if they just don't come back or don't reschedule.
Yeah.
Now, if they have an appointment, that's different, and they kind of cancel that or not cancel the no-show. A no-show is different than a ghost, in my opinion, because
a ghost is
a no-show is you're taking that spot on that person's calendar that someone else could have, and if you just don't plan on going back to that therapist, just try to cancel before 24 hours. No harm, no foul. I don't feel like clinicians should take that personally. And I think it's more a sign of, hey, I'm just not the right shoe for that foot, and I'm okay with that because I'm not going to be the right therapist for every person, and I'm not trying to be.
I think I don't mind. I don't mind the ghost or necessarily take it personally, but I think this is probably, something that I'm working on for myself. And so then I want to foster in my patients. Like, I've definitely ghosted therapists. So just to be fully honest, because it didn't fit and because it's easier and safer.
Yeah,
right?
It's easier than going in and saying to them, I don't feel like I'm comfortable with you. That's hard to say.
That's hard.
It can be scary and uncomfortable.
Exactly. So yeah, for me, it has felt safer when I ghosted, because I don't want like there to be any kind of conflict or issue. If I'm like, bringing up like I'm not happy with the way this is going and I would like to change, courses or whatever. But because I am working on assertiveness, right, and like being upfront, I tell my patients often that if they're dissatisfied with treatment or they are unhappy with me or if they have any kind of, sort of negative thoughts and feelings, which can come up in therapy, like transference, right? We have all kinds of feelings about our therapist that may be about our therapist, but may also be about our childhood. Like we tend to reenact, relationships with our, in therapy. So I try really hard to like convey very genuinely, because I do believe in attachment developmental work. Like I can adjust. Right? Like I can adjust. I want to. Right. Like, let's make this work. But, if not.
In my opinion, also, I imagine being ghosted earlier in treatment. If someone's been seeing me a long time, I'm hoping, and I would have said to them by now, hey, if I hurt your feelings or something happens where you feel like we're off relationally, the space is safe and I am safe enough to handle that. So that's in my mind where I think about ghosting.
Ghosting, you're thinking early on. I'm thinking anytime. You just kind of peace out without an explanation, I suppose, right?
Yeah. Well, I think today, what have you taken away? I know what I've taken away from today, but what have you taken away about this part 2 of how to find a therapist and the process of therapy in general?
I think the main takeaway that I had and what really got me thinking on this episode was just like how to tell if your therapist is a good fit, or when to depart, because I think that's helpful. It's just helpful to put words to my vibe, feeling, right? So I can like be a little bit more intentional in my own therapy and also think about it with my patients.
Interesting. Yeah, no, I'm taking away today that you are cooler than I thought. First. Okay. No.
Thanks.
I'm also taking away, like, for me, how hard this process is to start, how much emotional and mental labor it takes to start therapy, and how difficult it can be to find someone. I think I just have a deeper appreciation in conversation with you about the complexities of that. So that's kind of what I'm taking away. Yeah. Leave us a comment. Let us know what's hard to start for you and what things. Maybe you could let us know what you'd like a clinician to know about when you start treatment. That would be helpful for us.
Or if you actually do have like additional questions about this episode or part 1.
Send us a message. Leave us a comment. This podcast is intended for informational and educational purposes only and is not a substitute for therapy, diagnosis, or any kind of professional mental health treatment. We hope that we can share with you our experience authentically and genuinely, and we hope that occasionally we'll make you laugh. Maybe you can relate to our quest and how we're psyched for sanity. The content we share is our personal opinions and insights. They are not clinical insights to anyone, and they don't represent or reflect any entity that we work and or have worked for in the past. But if listening to this podcast has made you think, we really encourage you to seek out a mental health professional in your area.